Hello and welcome to Transforming Healthcare, the people behind the progress. My name is Joyce Shaw, Chief of Staff in HSE Technology and Transformation. Today I'm joined by Suzanne Brown, former Chief Nursing Information Officer in the Mater Hospital. Suzanne has 40 years experience in healthcare, starting her career with general nursing in the Adelaide Hospital, working as a general nurse before completing midwifery and neonatal nurse training in the UK. She then continued her career as a registered midwife in the Coombe, moving into nursing leadership roles and later specialised in health informatics, bringing deep clinical insight to the development and delivery of digital change in hospital settings. Suzanne, thanks for joining us. Suzanne, when you look back across your career from clinical practice into informatics and then your CNIO leadership role, what moments most shaped how you approached digital change in healthcare?
Well, I think that I'm not a digital native, so I got my first PC, I think it was in 2000, and I went to Trinity to do a general nurse degree programme, and it was only then in the second year of that I actually even heard of informatics. Never heard of it up till that point, so we're talking 2002. So I worked in the neonatal unit in the Coombe Hospital, and it was a real digital, it was a kind of a high-tech area, so I was used to that kind of high-tech, high-paced working, and I was interested in computers because they had just introduced a computer to look up lab results. So you could get your lab results on the computer and you could do the discharge on the babies. And I really found that was fascinating. That was the first time. Before that we'd been getting all lab results and everything. But a lot of people were terrified of the technology. So I used to end up showing them how to use it. And I then got the nickname of Suzanne, the IT nurse. And I was looking for something different to do. I kind of had been in the Coombe for 13 years and I was looking to kind of a new challenge, and I really wasn't sure where to go because I'd kind of pigeonholed myself to a certain extent in kind of neonates. And then when the degree happened, we had a module quality in informatics, and that module really changed my world because I found the informatics bit so exciting and how it could make a change to nursing. And one of the articles that I kind of reference for it was an article written by Rosaline Murnan and Una Marin from the Mater Hospital, and that's when I kind of realised that the Mater Hospital had a very good informatics team at that point. So I stayed on. I finished my nursing degree and I stayed on straight back to back and did a master's in health informatics. And at that stage in the country, really, there were very few health informatics jobs, clinical informatics jobs. They just didn't come up because they weren't out there, and people who got into them kind of stayed in them. And I was just really fortunate in the month that I finished my master's, the Mater advertised for an informatics job, and I applied and I got that. So kind of doing the degree opened my eyes to the informatics side. I would say what I always, my kind of thing always is, I'm always passionate about thinking what the nurse on the ground, what is of benefit to them. It's never about the system. You can have the fanciest system that you like, but if the staff don't use it, if they don't find it useful, it's pointless. So I always try and think, for the person who's going to use it, what are they using it for? Is it user friendly? Make it as simple as possible. So that's always been my focus. Obviously, like in the Mater, my kind of focus really was for nurses and healthcare assistants. So for nurses, I'm always thinking what will make their lives easier on the ward, what will help their patients. That's kind of the way I kind of look at any project, really.
In your CNI role, Suzanne, you've described it as multifaceted: education, training, system development, implementation, evaluation and ongoing support. What does that look like in real terms on a busy hospital site?
I suppose it depending on where you are in the Mater, we had an informatics team which I led out, and I had 4 4 nurses working with me. So my day-to-day work as kind of one of the team members would be different than when I was in the CNIO role. The CNIO role is kind of a real link between the IT side of it and the clinical side. So in the Mater, I was on the senior nursing management team. So I was a member of the nursing executive, and I sat on a number of committees as a senior nurse. So some of the things that I did was kind of really very nursing, aside from the digital piece at all. And then there was all the digital piece on top of that as well. So no 2 days were the same, and it really depended on what you were doing. I used to love the training side of it. I really did like training. As I got more senior, I didn't have time to do quite so much, but I always kept my hand in with the training. So a lot of our day-to-day stuff was training, managing our help desk. We had a help desk for all our kind of nursing queries to come in. Then depending on what projects were ongoing at the time, everything from, further implementations of certain things, upgrades. Then a lot of our stuff as well was looking at workflows. So a nurse would come to us, they would have an issue, not necessarily a problem, but they would like to see, is there, do we have a digital solution to help with an issue that they've found in their own work. So often we would go and sit with people, and we would work our way through workflows and see, do we have anything to offer them? And then other things. So we have, I suppose you could separate the things out in that we have an electronic patient record developed in-house, has been there for many years. But then we also have solutions that we buy in. So some of our solutions are homegrown, so to speak, and some of them are bought in. So Patient Centre, which was the name of our electronic patient record, that was our kind of built in the Mater. So we would support that. At this point, we're not doing more development in it, but there was still a lot of functionality in there. So we'd always be training new staff on how to use that. And then we would always do kind of one-to-one training if anybody had issues with it. But then we were also looking at solutions that we already had in place if we were upgrading. So we had one of my projects was I helped with the implementation of our patient flow system, which came in 2014. As I was leaving, we're looking now to upgrade that to a cloud-based version of it. And some of the functionality that we have in our current one, which people really like and couldn't be without, is not in the new cloud version, but the company has agreed that they will develop it for us. So it's about kind of, looking to kind of get that down on paper. What does that look like? And working with the company then to do that development. Then there's all testing, quality assurance when you get anything new in, to make sure that it is fit for purpose and does it work with the workflows that you have. So no 2 days are ever the same, and I think that's what makes it kind of exciting as much as anything else. I would sit on a lot of kind of steering groups within the hospital just for the informatics perspective, things like the quality care metrics, the tissue viability. So not necessarily always me, so I try to put that the team would go as well, because the job has to be bigger than one person. So you don't want anything to ever fall down just because one person leaves. So try to spread the work out between everybody. So can be challenging at times, can be very busy at times. And I suppose no 2 days are the same, but that's what makes it exciting. That's what makes you want to go into work and see what's going to happen on a day-to-day basis.
You've been clear about has to be beneficial, or it has to add value to the nurse.
Like from a nursing documentation perspective, like for a good few years now, I'd say people are sick of my mantra, but I have said that nationally we need to standardise nursing documentation. In the Mater alone, we have hundreds of pieces of nursing documentation. And in the Mater, most of our nursing documentation is still paper, it's still manual process. But there is so much documentation, and there's got to be a better way to do it. And we're a small country. We have a number of acute hospitals around the country. we can't all need different nursing documentation. At a basic level, we're all doing the same thing. So there has to be some standardisation of documentation across the country. Yes, of course, some hospitals have different specialties, so they'll have different needs. But there's a core piece of nursing documentation that everybody uses. If we all use the same, then it would help when nurses move from one hospital to another. They don't have to learn a whole new set of documents. They know already what the documents are. And if we want to compare ourselves and benchmark it against different hospitals, if we're not all capturing the same information, it's very hard to do that. So I really feel, and I know that now there's a project out looking at nursing documentation across the country, but that I've felt for quite a long time. We would have some very good documentation, but like a lot of hospitals, we would have some documentation that has been there for years and it's just continued because that's what it was. So I think it's a great opportunity to get a group together to look at what is recorded and really use evidence-based documentation and use the best tools that are out there. And standardise the documentation, because then you can kind of control your variations. You can see, if somebody's doing better than others, then you can look and see what they're doing. And it's about improving the data quality as well. And then that should help other things, like when you're collecting other data, like for the metrics and that, if you're already, you can't kind of develop one thing in isolation, you need to think of the outputs down. What are you going to use that information for? So only capture information that you need and that is useful. Because sometimes I think we capture an awful lot of stuff that really just sits in a silo and doesn't particularly go anywhere.
Suzanne, you've led hospital-wide implementations, for example, the bank management system and the electronic nurse referral system. What made those projects work and what did good look like in that situation once they were live?
I suppose two quite separate projects, so I'll just talk about them individually. Like the bank management system was a complementary system to our e-rostering system that came in 2000. So it was where staff could request bank shifts electronically. They would be filled electronically and it would go to payroll electronically. That was a solution that was developed in-house by our rostering developer. I was the IT lead for that project, but there was also the bank manager was the overall lead. And where that worked well was there was, I suppose, a variety of people leading out that project. So the people where it really hit. So the bank manager helped, I suppose, define the requirements of what the solution needed to be, because we were developing it in-house. So it would be developed and then we'd have a look at it, see did it actually fit in with the workflows, and it was quite an iterative project. And it was one where once that project came in, like all bank shifts continued to be requested, approved, filled electronically, and payroll is pulled electronically as well. So that project would have gone live in 2010, I think it was, and it's still there today and it works really well. We have since, we went in 2017, I think I started procurement for a new e-rostering solution. So originally our solution was an American solution. We were the only hospital in the country using it. And when we looked to get a new one, there was a HSE framework for rostering. So I thought it was more advantageous to take something that was kind of approved for ourselves. So we went out to the HSE framework and got a solution that included a bank solution. So that's what we're using now. But again, that is still going on today. There were a few teething problems. No implementation is without its challenges. More about change management. It wasn't really about the IT solution itself. Some people were not so keen to use it. They thought that how they did it on paper was how they wanted to continue. And it was really the bank manager that led out with that piece of it more than me. We did the training on it and we did the configuration on it, and we helped make any refinements that they needed. But from kind of, I suppose, convincing the staff that they needed it, it more lay with her. We supported each other in doing that. The electronic nurse referrals were different in that this project came about because a number of the CNSs approached Rosalie, and it was before my time. They were looking for a better way to get their referrals. So what they were finding was, in instances, the way they used to get referrals were phone calls, bleeps, bits of paper under their doors, passing somebody in the corridor, and they'd tell you there was somebody up in the ward that would need to be seen. And occasionally what they would find is by the time they got the message and they went to see a patient, the patient was already gone. So it just wasn't particularly efficient, and they were hoping that we could develop something for them. So that was initiated by a group of CNSs, and we eventually ended up with, the pilot group was 5 CNSs. So again, one of our, we have and still have developers, so one of our software developers worked with myself and the pilot team to develop this software. And again, it went through a few iterations. We eventually piloted it in 2010. It was one that it wasn't mandatory for any of the CNSs to use it. They could use it if they wanted to, but it didn't affect their work if they didn't. So in the first year or so, we worked with that pilot group. There were the 5 of them. I think by year 2, there were up to about 10 groups that were using it. But then it kind of sat for a while, because what happened is nobody else wanted to use it. They didn't see the value of it. I used to go out and talk to people, and some say, well, that's not going to work in my area. I used to say, you don't have to use it. If that's the case, you know, we'll work with the people. So what I did is really work with the people that were using it, and we refined it even more. And then what happened, by about year 2, it was the people that were using it were starting to say to the others, I don't know why you're not using this. This is so much better. And that really started to flow. And in fact, one of the people who was the most staunch, let's say, she really thought it would have no value to her, she became one of the biggest champions of it. She really pushed it. So by the time I left last year, I think we have something like 65 different groups using it. They recorded, I think, something like, I don't know, it was about, I think in 2024 there were about 160,000 visits were recorded electronically. And it gave them access then to their own data as well, because not only were they getting the referrals electronically, putting their notes in electronically, but they then had a dashboard where they could pull off their own reports. So they could then look back and see how many referrals they had over date ranges, what they were seeing their patients for, length of time they were spending. So they used to use that and everybody could pull their own reports, so they had access to their own dashboard. But also they used to then use it for business cases. If they were trying to say that they were, you know, how busy their service were, so people started using it for business cases and things like that. So I think that was one where it really showed that if the users, they have to find it useful to want to use it. And once they do, then it's a real snowball thing. So nurse referrals is kind of one of the things that's quite close to my heart, because I could see really the benefit of it.
Suzanne, your role sits between, you know, the clinical nursing focus on IT projects and the informatics focus on nursing projects. How do you translate between those worlds so decisions stay patient-centred and practical?
I suppose from my own perspective, like, I'm always thinking of the patient in the bed and how the solutions that we're looking at will affect them. So from a kind of a nursing perspective, on the groups where I sit with nursing with my informatics hat on, I'm kind of giving them the advice on that side of it, of what they, you know, what they want and how that will translate into a solution. Whereas on the IT side, it often is important to bring the IT people back to say, you know, you're trying to make all these decisions, but what is that actually going to mean for the patient? When you do that, what is that going to look like? In some instances, that side is, I think nursing understand more, because they are getting more solutions now. So I think they're more understanding that, if you do this, it will affect something else. Where sometimes IT maybe are quite focused on what they're doing and sometimes they may miss that if they do a certain thing, it will have a knock-on effect on something else. So often, certainly with my role in the information management services in the Mater Hospital, I was one of I was in a senior leadership group there, so I would go to the senior IT focus groups as well as then the nursing side of it. But it was always about bringing them back to what changes you make and the effect that it will have, because at the end of the day, that's, from my point of view, that's what I'm there for. What will that mean to the person on the ground and the staff? And I think what also is important is about building your network, building your community, because it's very hard. You don't want to be seen as somebody that nobody knows and now you're suddenly coming down and saying you're going to have to do it this way. So I was always certainly tried to be out there so that people would know me. So I would kind of build up my own networks within nursing, as well as kind of the IT side, because I already was living in that department. That was an easier one. But to get out to get myself known amongst nursing as well. So I'd build up all my connections. And I was part of what the nursing have their professional arm. So that was informatics, innovation, quality, practice development, so all that kind of nursing side of it. And I think that's where I tried to bring it in.
Digital for Care is our strategic programme. And when you think of it and look to the future, where do you think nursing informatics will have the biggest impact over the next 3 to 5 years, Suzanne?
I think that the next 3 to 5 years and the next 10 years, I think from a clinical informatics perspective, it's really exciting. In some ways, I think I came into it too early. I should have waited another 10 years because we knew what we wanted, but we just weren't seeing it. Whereas now, with all the new programs that are coming out with the national EHR, it is so exciting. And I think that the whole landscape is going to change so significantly in the next 3 to 5 you're seeing it, 10 to 20 you're really going to optimize it, and it just won't look the same at all for nursing, for all clinical disciplines. So I think it's a really exciting time to be in informatics. Now is the time, and into the future, we are just we're going to get what we have been talking about and wishing for the 20 years that I was in it. So I think it's really exciting, and there's so much good stuff that will come down the line. And to the benefit of everybody, to the benefit of the patients. I'm not saying that we won't make probably some little hiccups along the way. You can't implement big systems and not have a few little hiccups, but it's a really exciting time to be in informatics. It really is. And I'm kind of envious in some ways. If I had another 10 years, but I think now let the new energetic people come along and they'll see it right through to the end. But I think for Ireland, it really is going to change everything.
What advice would you give to nurses and midwives listening here now today who might be interested in getting involved in informatics?
I think that even if you staying at clinical practice at the ward level, you won't really nearly think about digital anymore. It just is how you will nurse. So I think that you can get involved and I suppose go down my route doing clinical informatics and that. I don't think you'll necessarily have to do that anymore because you'll be living it. But there will always be the case because it takes a huge amount of support to support staff to use the system. So you're always going to need that clinical informatics. All I would say is it's not for everybody. And I would have people saying to me, oh, I don't know how, oh, I hate computers. That's not what it really is about, you know, but it's not for everybody, and there is a skill to implementing solutions, and there's a skill to training people, and if that's your forte, go for it. There will be so many more jobs. As I say, when I started, and probably up to the last 10 years, there were very few jobs there. They just weren't out there. Here, if you really wanted that, you know, you waited till a job came up or you went abroad. Now there's going to be so much more jobs out there, but I think that the one thing that's lacking at the moment, and I know kind of work is going on about pathways, so for staff to move into those roles. At the moment, that's not really, certainly the Nursing Board of Ireland, that's not a recognised career pathway. Informatics isn't. When I did my Masters in Health Informatics, it's not recognised as the NMBI as a kind of a nursing Masters. That's got to change. So there's got to be a career progression. If we're bringing in all these solutions, we need staff to support that. We need people who have that informatics knowledge to support the staff on the ward. So I think there's going to have to be a lot more about career progression in that field, and kind of identified career pathways. I think, like, I was fortunate to go to the Mater because the Mater at that time was really ahead of the game with everybody, and that's because it was a voluntary and it could do its own thing, and they had a team of programmers to develop an EHR, and that worked very well in the Mater. Well, I think they're a bit of a victim of your own success, because if you have a solution that's so responsive to when people want to change, you know, that becomes a bit difficult when you bring in a big enterprise solution that is a bit more rigid and you can't get exactly what you want. So there are pros and cons to it all, but also, like, Mark Farrell was the EHR lead, and he was visionary. He really was ahead of his time. He saw standardisation and all that before anybody was really ever talking about it. And unfortunately, you know, he's not with us anymore, but he really was kind of visionary for the Mater. So the Mater, from my own perspective, you know, I was lucky to get to work there because they recognised the value of informatics. Because my boss, Rosalie, she started there in 1990 when they introduced test ordering. That's when she went over, and that's because Jerry Hurl, who was head of IT at the time, recognised that he needed somebody clinical to help bring it in, and she never left after that because they found that having that clinical person made a huge difference to their implementation.
Suzanne, thank you so much for your time today and for sharing your experience and insights with us. It's a great reminder of the impact nursing informatics can have for patients and for staff, especially when clinical and digital teams work closely together.
Thank you very much.
To everyone watching today, thanks a mil for joining us. You can follow HSE Technology and Transformation on our social channels to keep up to date with what's happening across digital transformation in the HSE, including programme updates, staff stories and opportunities to get involved.